Hello, everybody. My name is Guillermo Garcia-Manero from MD Anderson Cancer Center in Houston. I'm very happy to be here today at the ASH meeting in San Diego. We're going to be discussing topics related to myelodysplastic syndrome.
Hi, I'm Jamie Koprivnikar. I'm from the John Theurer Cancer Center at Hackensack University Medical Center. It's a pleasure to be here today.
I'm George Yaghmour. I'm the Associate Director of the Transplant Program at USC Los Angeles. Genuinely honored to join you today for this discussion.
I'm Sangeetha Venugopal from the Sylvester Cancer Center, University of Miami.
So moving forward, Sangeetha, so now you have the COMMANDS trial, phase 3, with a clear indication for at least RS positive. I also agree with you, RS negative in the front line. There's actually a study called the ELEMENTS trial that is starting to accrue for transfusion-independent low-risk MDS. I think there are some ideas about doing some studies in CCUS, but from a practical perspective, where do you see actually, if your wish list, what do you think will be one or two situations where you think it will be worth studying a drug like this for patients with MDS?
As you said, this is my wish list. So lenalidomide has a duration of response in del(5q) MDS, has a duration of response for like about 2 years. So what do we do after lenalidomide remains still an unanswered question. So all of these, like the Luspatercept or the next drug that is being under approval for imetelstat, they are all evaluated for non-del(5q) MDS. So what do we do after lenalidomide in del(5q) MDS? That's an unanswered question. And we do have a lot of patients in the clinic with like after lenalidomide. So
I totally agree with you.
Yeah, and they are like still lower risk MDS. They haven't progressed, and you kind of tinker them with AZA, with the HMA, and you still don't get enough responses. So what do we do in these patients? So that's an important question to be addressed.
I totally agree with you because those patients have been excluded from every study. And and the reason they've been excluded, I don't know if I know. Well, I may know. It's actually an FDA issue, right? Because there is a label for a very effective drug, lenalidomide, as you mentioned, Sangeetha. So they made you exclude those patients, but there's actually, to my knowledge, no true scientific rationale of why you will not treat a del(5q) minus patient with luspatercept. It's just because there's a very effective drug for those patients. We excluded them. And the interesting thing is that people will be treated, actually, in the community. So I agree with you that will be, I don't know that you need to do randomized studies, but it will be very beautiful to see phase 2 data on what happens if I fail lenalidomide. Do they respond to luspatercept or not? I totally agree with you. George.
Well, I mean, very great points. And honestly, I would love to see study also tell us, okay, you start the patient earlier and you intervene earlier. You're not going to put your patient on lifelong treatment, and if there is a point that you can know that there is a specific duration of response, and you can stop, and and then the need of reinitiation of the treatment at some point is going to be if you start the patient earlier and they are not requiring too much of transfusion. So the question is, patient would require this treatment the rest of their life? What would be the endpoints for the duration if you can stop at some point and see how many of those patients would maintain and overall survival? Because we have improved the survival definitely in MDS, including low-risk MDS. And we know anemia is a major prognostic factor for overall survival now, based on large database publication from many centers. And I would like to see in the future also some study telling us about if we stop, when do we stop, and what is going to happen to those patients.
I think that's very important. And then you also mentioned about survival. Traditionally low-risk MDS, we never talk about this. But I think Dr. Komrocki had a presentation at this meeting or not too long ago showing that in the MEDALIST trial, responders live longer, actually. And to me, many years ago, I thought this was kind of like a tautology. I never understood, okay, you improve your anemia, you're going to live. But it's actually significantly more complex. So I would like to see some long-term analysis of survival from COMMANDS, actually. I think that will really reinforce, this issue. And I think this question of when do you stop, particularly drugs that is probably not very cheap, right? So how many...
And also transformation to a more advanced level or acute leukemia in the long run.
What about you, Jamie?
Well, I think it's a very interesting question. Is this really a disease-modifying agent? Is it just by virtue of the fact that it obviates the need for transfusions that we, saw that increased survival benefit in medalists? And so I agree with you. I'm really excited to see more mature data from the COMMAND study.
So my final thoughts for Luspatercept is this is the first line agent. Now I would be more prone to using, not even more prone, I would definitely use Luspatercept in first line because this is the drug that was actually trialed in patients with non-del(5q) MDS. And I'm looking forward to the data on how does this risk classifications, especially IPSS-R, IPSS, and IPSS-M, matter in the context of the Luspatercept among patients with del(5q) MDS. And I did see that it upstaged, the IPSS-M, upstaged some 20% of patients from both IPSS-R and IPSS. So I would want to know more about it. And one other thing I'm curious to know about is what is the role of TP53, because it was IPSS-R, so it did not take into account the molecular profile. So what does the TP53 mutation did to those patients who were treated with Luspatercept on this clinical trial? So did they stay the same, or how did it progress? What is the leukemia-free survival, and what was the transfusion independence in those patients?